So at ASH 2025, I had the chance to present long-term progression-free survival for patients with standard cytogenetic risk included in the CARTITUDE-4 trial. So the CARTITUDE-4 trial is one of the few randomized trials ever reported with a BCMA-directed CAR-T therapy in multiple myeloma. Enroll patients with 1 to 3 prior lines of therapy that were PI exposed, who were lenalidomide refractory, and could have been daratumumab or other anti-CD38 therapy exposed in or refractory. This trial reported before, it has been updated. It shows that cilta-cel gives better progression-free survival and overall survival over standard of care triplet regimens, which in this trial was DPD or PVD. Because of the somewhat complex plan of care that involves apheresis, breathing therapy, and administration of CAR-T, there's a tendency to prioritize patients with high-risk disease, which is clearly a benefit from this therapy. But the emphasis here was to show the advantage, it shows the proposition of how this therapy could be beneficial even in patients with cytogenetic standard risk disease. So what we did is, the straight comparison by intention to treat has been presented before, showing great advantage for cilta-cel over standard of care. And here what we did was we focused on a cohort of patients, 60 patients, 59 patients were infused with cilta-cel and had the standard risk disease. And the standard risk definition here included patients who did not have 1q, deletion 17p, translocation 414, or translocation 1416. And we also expand that definition to include the patients who had this 1q gain amplification as the sole abnormality in order to mimic the population that we saw on CARTITUDE-1 with standard risk disease, since that definition in that study include those patients. And what we see is that patients with treated with single dose of cilta-cel have at 30 months, so 2.5 years, progression-free survival of 80%. If we include the definition of the ones who had 1q gain amplification, you still talk about 73%. And that is far superior to the less than 60% that you see on the CARTITUDE-1 trial with the same cytogenetic definition of standard risk. We had a chance to do some interesting landmark analysis, looking at the patients who arrive at the end of the first year without progression, which is the vast majority of the patients. And of those patients, 93% of those remain progression-free after 1.5 years later. And those who are MRD negative, which again was more than 80%, none of those had progression in the subsequent 1.5 years. I think this builds into the impression we all had from the CARTITUDE-1 trial that some patients treated with cilta-cel in late lines therapy might actually never face a progression. We had that possible plateau at 5 years for 1/3 of the patients on CARTITUDE-1. And what this tells us is not surprisingly, that proposition of potential definitive therapy might be applied to a lot more patients that the 1/3 that we saw in CARTITUDE-1 as we use this therapy in standard risk patients in earlier lines of therapy. So it really makes a case for early use of this very effective therapy.